Good morning, good afternoon, good evening, or good night to all of you colleagues that are connected to Dübendorf for today's webinar. I'm Paul Romans. I'm the director of the Department of Orthopedics and Traumatology at the Mainz University Hospital. Mainz is situated near to Frankfurt in the Midwest of Germany. On my right side is Rudolf Elmer helping me for technical questions, and in Innsbruck, connected to us, is René Attal, working at the Department of Traumatology there, and he is our moderator and will coordinate your questions and answers. If you have any questions or to me or to the moderator, please bring them in the section on the left bottom of your screen. The title of the webinar of today is Intramedullary Nailing of Metaphyseal Fractures of the Tibia. What are the learning outcomes? We should recognize the importance of reduction of the metaphyseal fracture before we start nailing. We should use appropriate aids and tools to obtain this fracture reduction before and also maintain this reduction during nail insertion. We should identify the correct entry portal and recognize its key importance for optimal nail positioning and fracture alignment. And we should apply specific techniques to facilitate the correct nail placement and final positioning. Tibia fractures are the most frequent fractures of the long bones. We distinguish between proximal fractures, shaft fractures, and distal fractures. Proximal fractures are rather uncommon. They represent 7 to 12% of all tibial fractures. Most commonly, they are the result of a direct trauma mechanism, and therefore they have a high incidence of moderate or high soft tissue trauma. According to literature data, distal tibia fractures represent 37 to 50% of all fractures. They can be the result of a direct or most commonly an indirect trauma mechanism, and they have a lower degree of moderate and high soft tissue trauma than the proximal fractures. We know that locked nailing today is the treatment of choice for tibial shaft fractures, and there are many reasons for that. We can expect an uneventful bone healing and an excellent functional outcome in most of our patients. There are distinct biological and mechanical advantages. We are talking about a closed procedure, so there is no additional damage to the soft tissues in the neighborhood of the fracture. There is an enhanced periosteal blood supply when we ream the intramedullary canal. And the reaming debris is osteogenetic, osteoconductive, and also osteoinductive. We have distinct mechanical advantages. When we implant a nail, this is a weight shearing implant in the center of the axial load of the tibia, giving adequate stability and enabling a very early partial and also early complete weight bearing. You see now a video of a humeral shaft fracture to show you that fractures at the isthmus are reduced by insertion of the nail. The rigid nail fits within the narrow intramedullary canal, and by pushing the nail forward, the fracture fragments will be realigned. So there is an alignment between the proximal and distal fragment, and we only need to adapt this alignment to a more correct form. This is not the case in metaphyseal fractures. The reason is that there is no narrow endomedullary canal in the metaphyseal area. So nail insertion by itself will not reduce the fracture. And when the nail is locked, as you see on the left picture, to fix an unreduced fracture, this can lead to a fixed malalignment, a large fracture gap, and this gives a higher risk of delayed union and non-union. Here is my first question for you. This is a 47-year-old male with a segmental fracture of his tibia. These are closed fractures and there is a moderate soft tissue damage. How would you treat this fracture? You see, we have 6 options for you. The first is a long lateral angular stable plate as a single implant. The second option is an angular stable plate proximal and a second angular stable plate distal. The third option would be a double plate proximal, one medial and one lateral, and a lateral plate distal. The fourth option is an angular stable plate proximal and a nail for the diaphyseal fracture distal. The fifth option would be a nailing only. And the sixth option is other solutions. Okay? We will end this poll and show you the results of this question, your answers. So most of you have chosen for a nail solution. I think that this is a correct answer. This fracture can indeed be nailed, but we agree that this is a difficult procedure. So if we nail these fractures, there are several prerequisites. We need a preoperative planning in which we thoroughly analyze the fracture pattern, especially this of the proximal fracture. We will need a reduction of the metaphyseal fracture before we start the nailing procedure. And to reduce this fracture, we will need reduction aids. And we will determine these aids before we start the procedure in order to have these tools in the operation theater before surgery. We must secure the reduction during nail insertion, and this may ask for additional tools. And finally, we will need a specific implant to deal with this specific biomechanical problem. What kind of reduction aids do we have available? First of all, there is the fracture table. There are distinct advantages in using a fracture table. We obtain a provisional stabilization of the leg with an alignment of the fracture fragments. This alignment will be adequate but not optimal. Moreover, there is a control of length and rotation of the broken leg. But there are also disadvantages. On a fracture table, the knee is flexed in a fixed position of about 90 degrees of flexion. But in the nailing procedure, we may need different degrees of knee flexion during reduction and nail insertion. Another option is to use a mobile traction device. This is a sterile device that is put on the operation table, and the leg is put on this device. The advantage is that the knee flexion can be changed during the procedure. When you ask me, where is this device available? Well, this was made by our technical department at University Hospital. So there is no patent on it, and you can copy it if you want. Additional reduction aids can be the use of the external fixator or large distractor as a joint bridging or non-joint bridging device. We can perform an open or closed reduction with a pointed reduction forceps, which is optimally used in oblique and spiral types of fractures. A shank screw as a monocortical screw can be used as a joystick to manipulate one certain fracture fragment. And also key wires or lag screws can be used. They should put in outside the endomedullary canal in order not to disturb the pathway of the nail. Here you see a proximal tibia fracture with an intra-articular extension that is reduced and realigned with the help of two external fixators, one on the medial side and one on the lateral side. And both fixators are joint bridging. In the middle, you see a lateral view of the same situation. On the right, you see a distal tibial fracture that is reduced, and the reduction is controlled by a large distractor that is non-bridging, which means that the proximal and distal shank screws are put in the tibia itself. Here you see a patient with a spiroid fracture in the distal third of his tibia, the preoperative X-ray on the left. In the middle, you see an intraoperative view of the use of the reduction forceps to close the fracture gap of this spiroid fracture. And on the right side, you see that after complete closure of the gap, we can put in a guide wire in an optimal position. In this case, the patient had a long oblique fracture in the distal third of the tibia. The fracture was reduced with a pointed reduction forceps and controlled with one lag screw that is put anteriorly of the endomedullary canal. After that, a bridging implant, which was the nail, is inserted, and you see a triple interlocking of the distal fragment, which obtains high stability. Here you see some intraoperative views of the treatment of this proximal tibia fracture with an undisplaced extension into the knee joint. In the colored pictures, you see the use of a ball spike to close the fracture gap anteriorly. You see the use of an external fixator, a non-bridging external fixator, with one screw in the proximal fragment and another screw in the distal fragment. You see a pointed reduction forceps, which is placed over the main fracture. And you see the insertion of a polar screw, we will talk about this later on, from medial to lateral to guide the nail into a good direction. Here you see some additional intraoperative views. You recognize one shank screw of the external fixator. You recognize the polar screw. You recognize a forceps and another forceps for reduction of this fracture. And here you recognize the part of a drill that is used to put a lag screw for closure of the main fracture gap. After that, the knee can be flexed up to 110 degrees, and it's easier to put in a guide wire before the puller screw and after the shank screw. And here on the right side, you see the end result with the lag screw in place, the puller screw in place, and 3 different interlocking screws for high stability of the proximal fragment. And this is the post-operative result. You recognize the lag screw on the lateral view, and on the AP view, you recognize the puller screw, and you recognize the triple interlocking proximally, and the distal interlocking is a double one. There is a perfect alignment in AP and in the lateral view. Before we start the nailing procedure, we would like to draw your attention to some key points for optimal nail positioning. First of all, you have to choose a correct entry portal in order to avoid any malalignment. Knee flexion should be possible up to 110 degrees. We recommend to use a guide wire and always use cannulated nails in case of nailing metaphyseal lesions. And we may use intramedullary blocking or so-called puller screws to guide the nail into its correct place. Here you see a drawing of the tibia plateau with a sweet spot, the so-called sweet spot, where an ideal entry portal for nail insertion can be found. It is situated between the medial and the lateral meniscus and in front of the insertion of the anterior cruciate ligament. In the second drawing, you see that this entry portal is situated just behind the Hoffa's fat pad. Here you see that in the AP view, that the entry portal must be situated just in line with the central axis of the endomedullary canal. This is not possible in the lateral view because the central axis goes through the tibia plateau, but therefore we have a curved nail and the entry portal can be somewhat more anteriorly. If we use a two medial or a two lateral entry portal, we will inevitably go into a valgus or respectively a varus malalignment, which is very difficult to correct after nail insertion. The same is valid for the entry portal in the coronal plane, in the sagittal plane, excuse me. If you have an entry portal which is too anterior, and you see the red line which is showing us that, then the pathway of the nail will show towards the dorsal cortex. So it threatens to perforate the dorsal cortex with an additional fracture as result. So here it's clear that we need more flexion of the knee joint in order to be able to insert the nail more in line with the endomedullary canal, and this is showed by the green line in the drawing and in this intraoperative lateral view. What are the advantages of the use of a guide wire? The guide wire's tip determines the location of the nail's tip. So when we place the guide wire centrally in the distal block, just above the ankle joint, the nail will be placed over the guide wire and will find exactly the same position. If we ream over the guide wire, we will have the additional advantages of the reaming debris. that supports the bone healing. But we recommend not to ream until very distally, but just to ream distal to the isthmus so that the nail is inserted in a solid spongious bone in the distal block, and there is no risk of secondary malalignment. And a thicker nail, thanks to reaming, gives you a higher stability of the bone implant construct. Here you see a very distal fracture of the tibia that is reduced by a large reduction forceps, and then a guide wire is brought in. The blue areas are the fluoroscopic views intraoperatively, and you should make sure that the tip of the guide wire is really in the center of the distal block, as well in the AP view as in the lateral view. If we then insert the nail, the tip of the nail will be placed exactly where the guide wire is, and this is an ideal position for interlocking. Here you see the same patient as we have seen before with his oblique distal third tibia fracture reduced by a pointed reduction forceps. After that, a guide wire is put intramedullary, and you can recognize the correct position in the lateral view and in the anteroposterior view, and after that the nail is guided over this guide wire. At the end we have a correctly placed nail with a triple interlocking distally, and additionally a medial malleolus fracture was treated here with 2 lag screws. What are the characteristics and the advantages of intramedullary blocking or polar screws? They are artificially narrow the intramedullary canal in the metaphyseal area. So they create, let's say, an isthmus there where there is no isthmus. Therefore, screws or key wires can be used. They direct the guide wire, or if you use a solid nail, they direct the solid nail to its correct final position. These blocking screws must be placed opposite to the apex of deformity. So that means lateral to avoid a valgus deformity, and posterior to avoid an anticurvation or apex anterior deformity. They may add to the stability of the whole construction, and also an additional advantage is that they may block a false pathway of a previous nail insertion. Here you see the same patient again with an intraoperative view of a nail insertion. If we go further with this direction, the nail threatens to perforate the dorsal cortex of the proximal fragment and creates an additional fracture. So if we place a polar screw just in this path of the nail has to go more dorsally or more ventrally of this screw. In this patient, it is clear that the nail should go more ventrally, and this is depicted with the green arrow. We can use these polar screws in the coronal plane, but we also can use a polar screw in the sagittal plane to avoid valgus or varus malalignment. And here you see such a polar screw that avoided the nail to go in too dorsally. The same is true for the distal tibia. In this example, you see that the nail goes too medially because of a remaining valgus malalignment of this fracture. If we take this nail back and put a polar screw just in the trajectory of the nail cannot go in there anymore and must choose a way more medially or more laterally. Here, a more lateral way will be chosen, and at the end, the nail will be placed in its optimal position in the distal tibia fragment. Alternatively, we can use different Kirschner wires below each other in a so-called palisade technique, and they also will prevent a too medial position of the tip of this tibia nail. And you see with these three wires, the nail is forced into a central position. We can take out these Kirschner wires thereafter, and we can perform a normal interlocking. Here you see a clinical example of this. This is a very unstable distal tibia fracture. The nail here was put in too anteriorly, so it was retracted partially. One Kirschner wire is put in the anterior part of the distal fragment, pushing the trajectory of the nail more posteriorly. A second Kirschner wire is placed below the first one, and at the end, the tip of the tibia nail is coming in an ideal position in the center of the distal block. After that, the nail can be interlocked and the Kirschner wires can be removed. It is also very important to use specific implants if you nail metaphyseal lesions. This means that we use multiple interlocking screws in different planes, and the design of the nail must allow that. Multiple interlocking screws will provide a high stability against axial, torsional, and bending loads. Here you see the segmental fracture that we have seen at the beginning of the lecture. What you recognize is a triple interlocking proximally, a triple interlocking distally. You recognize the lag screw, and you recognize a polar screw on the medial side of the nail. If you look at the lateral view, you see a correct alignment of the main fracture, and on the right side, you see a nice healing without any further operation. Here you see a very distal tibia fracture, a multifragmental tibia fracture that is treated with an antegrade expert tibia nail, and we recognize again the triple interlocking in the distal fragment and the central placement of the tibia nail in this distal tibia fragment. Here we see a pilon fracture that was treated first with an angular stable plate. But as you can see, the pilon part of the fracture healed, but not the metaphyseal part. You see a remaining fracture line, and you'll see as well implant failure, which means the breakage of 3 screws proximal to that fracture line. If you look at the CT cuts, then you see the remaining delayed union, or you can say non-union of this fracture above the malleolar fork. What we did is to remove all implants, to ream the intramedullary canal and use the reaming debris inside the pseudarthrosis, and to put an expert tibia nail with a quadruple interlocking in the distal fragment to have the highest possible stability for an eventful healing. Here you see a post-operative view about 1 week after the surgery. And this is another example. This was an alcoholic patient that was treated for an open tibia fracture with an external fixator first. You see the holes of the external fixator device that now is removed. The patient disappeared and came back 8 months after trauma. And you recognize a severe malalignment, a pseudarthrosis, and a shortening of this broken leg. We did not want to go into this pseudarthrosis from the medial side because we were afraid of soft tissue healing problems. So what we did is to go in from lateral, and through the fibula pseudarthrosis, we opened and debrided the tibia pseudarthrosis. We realigned the fracture fragments and put in a reamed, and you see a thick intramedullary nail with a quadruple interlocking of the distal fragment as well. As in the previous case, we used the reaming debris for the closure of the non-union. We did a double plating on the lateral side to compensate the varus tension that still existed in the soft tissues. Here you see the result 3 months and 6 months after surgery, showing you a nice healing of this difficult fracture in an acceptable alignment of the distal tibia fragment. So now here I have a second question for you. This is a 58-year-old woman. She had a direct trauma of the proximal tibia, but it is a closed fracture with a moderate closed soft tissue damage. There were no vascular injuries and no neurological damage. So we speak about an AO type 41C2 lesion, which means a metaphyseal complex and an articular simple lesion. I'll show you now the possibilities of treatment. First of all, a lateral angular stable plate. Secondly, a lateral angular stable plate with a medial buttress plate through another incision. Third, a hybrid external fixator. Fourth, a nail. Or fifth, other solutions. What would you do if you have this patient in your hospital? Thank you very much for your answers. Yeah, you can see together with me that most of you would prefer a nailing. That's nice to see and read, but certainly a high number of colleagues also prefer a double plate osteosynthesis, meaning a lateral angular stable plate with a medial buttress plate. Certainly, if you have a moderate soft tissue damage, this double incision may be a risk for wound healing problems. So you see now what we did. If you analyze the lateral view of this fracture and you draw a line in the center of the endomedullary canal and you follow this line more proximally, you will see that this line is just situated in the retropatellar space. So just between the patella anteriorly and the femoral condyles posteriorly. So the question comes up if this is a good candidate for a retropatellar pathway or a suprapatellar entry point. What are the possible advantages and what is the disadvantage of such a procedure? A retropatellar pathway gives you a pathway that is in line with the axis of the endomedullary canal. You see that the knee is about 30 degrees flexed. The correct entry portal, the so-called soft spot at the tibial plateau, is easily to identify and to access. The nailing is possible in the supine position without traction table just with a slight knee flexion, and in this position reduction of the fracture fragments is much easier than in knee flexion. Specific instruments are needed to protect the cartilage because the pathway goes through the knee joint, but we have not enough experience to know if there is a irreversible damage to the cartilage by using this pathway. Here you see that we choose this retropatellar pathway with the suprapatellar skin incision in this patient. You recognize the instrument creating the pathway between the patella on the left and the condyles on the right side of your picture. You see the guide wire introduction without any bending, so going through the knee joint itself, and at this point acceptable axial alignment in the AP view. After correction of the alignment and a slight reaming of the isthmus, we put in an expert tibia nail, here with a quadruple interlocking in the proximal fragment, because we expect a longer healing time due to the multi-fragmentary fracture. And here you see this result. There is no polar screw or lag screw necessary because of the very easy introduction of the nail into the tibia through this retropatellar way. But as I mentioned, we need a high stability in the proximal fragment, and therefore in this case we used 4 interlocking screws in this area of only 5 to 6 centimeters. So I am at the end of my lecture, and I see that many of you have asked me questions, and now I can start to answer some of them. From India, I have a question. Would it be better with an entry point in the suprapatellar approach, with the suprapatellar approach? I think that I could answer this at the end of my lecture. The question remains, which patients are good candidates for the suprapatellar approach? Personally, I would not use this approach in young patients because I do not want to damage any cartilage. Secondly, I think that there is strong musculature, so the quadriceps muscle is pushing the patella towards the condyles, and it is more difficult than in older patients to create this pathway. So I would limit the use of this approach to older patients with weaker muscles. There is a question from Argentina. In any case, do you stabilize the fibula? Well, we have learned that if we use the expert tibia nail and we interlock 3 times or 4 times this distal nail, or the nail in the distal part, then we do not need specific osteosynthesis of the fibula anymore. The fibula itself also can hinder a slight dynamization of the fracture, and there could be a higher risk of delayed union and non-union. But if you are not sure about the stability of your nailing construct, I would advise to additionally plate the fibula if it is broken at the same level as the tibia fracture. I have a question from Croatia. You are using a lag screw absolute stability for nail, which indeed has relative stability. Can you explain mixing of these concepts? Yes, I can do. This is just the same as we do in plating procedures. In a simple fracture, just as small oblique fractures and spheroid fractures. Also with plating, we will use a lag screw first, and the plate is then a neutralization plate, which is placed over the main fracture area. This is the same principle we use here. We close the fracture gap with the screw, and then we bridge this fracture gap with another implant, which is the nail. If you would do biomechanical load on, put biomechanical load on this construct, you would also see that there is no absolute stability with one lag screw, so there is still some movement possible, and healing is possible with callus formation periosteally. I have a question from India. Can we remove the polar screw after locking? If you mean that the polar screw adds to the stability of the whole construction, that means that there is a direct contact between the nail and the polar screw, I would not remove the polar screw. But as I showed you in one case, there is no direct contact between the polar screw and the nail, then the screw does not add any stability anymore, and you can certainly remove it. If you use Kirschner wires, I would remove these wires always. I have a question from Russia. Can we allow the light weight bearing after a distal fracture of the tibia treated with a nail like the ETN? In my opinion, if you did a good job, you closed the fracture fragment and you had multiple interlocking in the distal fragment, then you achieved a high stability, and I would certainly allow weight bearing until 15 to 20 kilograms immediately, and then following the patient with X-rays, I would go to full weight bearing if there is a nice fracture healing within 6 weeks of time. I have another question from India. How do you reduce the short proximal fragment which goes into extension due to the pull of the patellar tendon? This is very nice. This question comes up again and again. Certainly, you have to close your fracture gap with the pointed reduction forceps. Personally, I prefer to use a lag screw additionally to this pointed reduction forceps because it adds stability. After doing this, I try to flex the knee up to 110 degrees, and I look at my fracture if the fracture in this movement remains stable. If the fracture remains stable, I can go on with my nailing. If the fracture opens again anteriorly, I can add a second lag screw or even a small plate additionally over the fracture gap that I will remove after nail introduction. I have a question from Egypt. Why not use the lateral parapatellar approach with a lateral entry point in the last case? Certainly, you mean the case with a suprapatellar skin incision. This is certainly a topic of debate. I cannot answer you if a suprapatellar skin incision or a retropatellar approach is better for the patient than opening the joint in a conventional way. But we have to admit that the lateral parapatellar approach is a large incision opening completely the joint with some problems for the joint, and not treating the joint, but here we treat in fracture in the neighborhood of the joint. So I do not know really what is the best. Gaining experience with the two methods will bring us the answer. I have another question from Egypt. What is the rate of pseudarthrosis with nail fixation of metaphyseal tibial fractures? What would you do in this case? I cannot tell you exactly because in the literature, I mean that there are no large series until now about nailing of metaphyseal fractures, proximal metaphyseal fractures of the tibia. I do know some publications of case series of about 40 patients with very good results, but they may not be representative for the expertise in other centers. So what to do? You have to look at the kind of pseudarthrosis you have. If you have a hypertrophic pseudarthrosis, then there is a need of additional stability. Sometimes this is due to a larger fracture gap, and then the solution will be to close the fracture gap in removing this interlocking screws, perhaps bringing an additional plate over this fracture and then putting the interlocking screws back. This would be a possible solution. If there is an atrophic pseudarthrosis, which means large fracture gap, no callus build, no callus formation, and lack of stability, then I would switch towards a plate osteosynthesis, open reduction of the fracture, and cancellous bone grafting, perhaps in combination with additional BMPs. I have a question from Morocco. Do we ream after or before putting the polar screws? I think it is depending on at which stage you will need these polar screws. If it is difficult to put in your guide wire in the optimal way and in the optimal place, then you will already use the polar screws in this phase of the procedure, which means in the phase of introduction of the guide wire. Then reaming will come afterwards. But if we have no guide wire and we want to insert a solid nail, then certainly gentle reaming and using a somewhat larger nail is advantageous. And then if you want to place the solid nail correctly after you have reamed the isthmus, then you may need polar screws after reaming. Can we use a plate, a question from India, to avoid extension of the proximal fragment with a nail? I just answered that you can do this, but please do not open your fracture too far and do not add additional damage to the soft tissues, because then you lose the advantages of intramedullary nailing. Certainly, it is important to bring in your implant correctly so that after the procedure, you may expect an eventful healing. And you do not accept any fracture gapping after nail placement. A question from Sweden. Is it possible to avoid penetration of the knee joint cavity in tibia nailing? Well, if you do not use the suprapatellar approach as just depicted, then the soft spot or the sweet spot is situated in front of the joint space, which means that the synovia does not to have be opened for this nail introduction. The fat pad of Hoffa is protecting the synovia, and we can go just behind this fat pad, but in front of the synovia. Another question from Hungary: do you use ASLS in the distal part? Certainly, we use it as in other nailing procedures. This is depending on the quality of the bone in this patient. If you have more osteoporotic bone, then we will try to enhance stability by using ASLS. If you have very short distal fragments and you are not able to put more than 3 screws, you also may use 1 or 2 ASLS screws to enhance stability. I have another question from Ecuador. What is your opinion about nailing of the fibula 2? I already answered that nailing of the fibula or osteosynthesis of the fibula is not compulsory in case we achieve a high stability in the tibia, especially in the distal tibia fragment. But if the fracture is situated very near to the ankle joint, it may be beneficial to do any form of osteosynthesis for reconstruction of the malleolar fork. What kind of osteosynthesis you prefer? Certainly, it is clear that plate osteosynthesis enables you an anatomical reduction and fixation of the fracture, and I would say a nailing is more a splinting of the fracture, where I do not think that it adds much to the overall stability of your construction. The advantage of nailing is that you use here a percutaneous procedure and you do not open the soft tissues at the lateral side of the distal leg, which may be advantages, let's say, in diabetic patients, as an example. I have a question from Austria. When do you remove the nail? What's the earliest point of time? Well, if there is no complaint when the patient has no complaints that are directly related to the implant or to the screw heads, I would wait for removal at least 1 year. Certainly, you have to look at the fracture healing and at the subjective well-feeling of the patient. If the patient is full weight bearing, has no complaints, then the nail can certainly be removed, depending on what the X-ray is telling you. Personally, I would wait about 1 year. Suprapatellar approach cause patellofemoral osteoarthritis, a question from Bangladesh. Thank you for that. I think that I answered this question partially. We do not know if this is the case. We may think that this is possible because we introduced the foreign material inside the knee joint, and therefore we need more experience to know what happens with these knee joints where the tibia fractures has been treated like this. Personally, I repeat that I would not do and would not use this approach